Today on the Roundtable Perspective, Dr. Catherine Gillotti joins me to discuss how bad news is delivered in healthcare settings. We will talk about the history of this a little bit. To what extent have doctors been prepared in the past or not prepared to deliver bad news? And what are they doing now in medical school? Dr. Gillotti, with her background in interpersonal communication, offers a bit of a critique on some of the methods. And she also has a website that she runs where patients can leave stories about their experiences with their doctors, and she will share some of that information with us as well. Additionally, we talk a little bit about the ethics that are involved in this. What should a doctor say, and is it okay for a doctor to hold something back? There's a method recommended called dosing, where you give the patient a little bit of the information at a time, and the question there is, of course, is it fair to hold back information that maybe the patient needs to know or wants to know? Welcome to the Roundtable Perspective. I'm your host, Tom Roach. I'm joined today by my guest, Dr. Catherine Gillotti, and we're going to discuss how doctors deliver bad news. Dr. Gillotti has a Ph.D. from the University of Kentucky in interpersonal communication, and she's published somewhat extensively on this, conference papers and book chapters on health communication related topics. So how do doctors feel about getting advice from someone with a Ph.D. in communication?
Well, I think it's been my experience, it depends on the doctor.
Yeah.
So some of them have not been very receptive at first, because of course they're the ones on the front lines doing it. But as the years have passed, it's now part of their training, interpersonal communication skills training, for their continuing education credits. So they're a lot more receptive than they had been in the past.
Right. Yeah, it's not something we have a lot of experience with. The worst news we deliver at the university is you're not passing this class. You know?
Right, which is a form of bad news.
But most people survive it.
Right,
yeah.
correct, correct.
Right. The current study is looking at bad news delivery from the patient's perspective, right? Can you tell us a little bit about that?
Yeah, so in the spring, I went on sabbatical from the university to dedicate myself to this study. And what I had been doing in the past has been always looking at bad news delivery from the care provider's perspective, but not focusing as much on the patients. Of course, it's an interaction, so there's two people involved. But a lot of the research and literature that's been written on bad news delivery has been written from the care provider's point of view. So I decided, well, let me step on the other side of the spectrum. And I saw this gap in the research literature between how news is delivered and its impact on patient decision making. So I wanted to see if I could create a study in which I would be able to collect stories from actual patients who've been on the receiving end of bad news to see if there is any impact at all on the way the news is delivered to them, and then their subsequent decisions about their health care.
So when you say patient decision making, just some examples maybe for listeners, what are some decisions that patients make?
So let's say that you have a man and he's diagnosed with prostate cancer, right? And there's multiple treatment methods for prostate cancer. He might have surgery to remove the cancer, but he also might have radioactive seeds implanted in order to treat almost like a chemotherapy or radiation therapy that's sort of ongoing. They each have different, or he may decide to do nothing at all. It's up to the patient, right? And they have to decide how are they going to go about their treatment for this. And so I wanted to know, and want to know, is the way news delivered to them impact their decision? Or let's take on the female side, a woman is diagnosed with breast cancer. Does she decide to have a lumpectomy, or does she have a mastectomy? Or does she do nothing at first and do radiation and chemotherapy, right? So there's all these decisions that have to be made. Those are pretty drastic cases of cancer diagnosis. But how is the news delivered to them and their prognoses for what's to come does that impact their decision making?
And the other thing that comes to mind as a layman listening to this is, what about their, emotional, psychological side? I mean, are you looking into that at all, or you're purely just looking at what impact it has on the decision making?
Well, so the study is set up for people to be able to tell their own story.
Yeah.
So I created a website, a dedicated website where I explain the study and ask people to submit their story to me through the website itself. So I let the patient initially, the participant, tell me where they want to go in terms of their story delivery, but I also then am able to contact them through email and with follow-up questions. I actually did that this morning with a participant where a person chose to have a mastectomy, and I followed up with questions about, well, what options were laid out in front of you, as an example. So at this point, I just want people to tell their story as fully in their own voice as possible, and then as it's progressing, I'm following up with questions that will allow me to get into more specifics if they haven't covered them.
Right. So they might just naturally go into more personal reaction kinds of things that you may end up collecting.
Exactly. And I wanted to take this sort of qualitative inductive approach so that I wasn't directing the patients on what to tell or what not to tell, but to just see what do they tell, what is their story. What I'm finding fascinating is that there have been over 1,300 visitors to the website.
Oh, really?
But
That's
to date,
very successful.
I have 5 stories.
Really?
Yes. So it's fascinating to me as a researcher from a methodological standpoint. Because what I used Facebook and LinkedIn and email to promote the study in doing this sort of snowball sampling. I've asked people to share the link to the website and to send me a story themselves if they have one. So it's being shared. The link is definitely being shared.
Yeah, people are reading it,
And they're going to the website. But I don't know if it's because it does take a little bit of time to sit down and actually write your story out and send it.
Well, plus it's a very personal
And some
to
people
talk
may
about,
decide they don't want to do it.
Yeah, interesting. In terms of your methodology here, I mean, obviously you can't force people to tell you these stories, so I'm speculating here, but you're hoping that people see that others have done this and they're connected to them on Facebook, and that might inspire them to tell their own stories, for instance, right?
Correct. And I've even, what inspired me to use social media was just in my own Facebook usage. I noticed people would get online and talk about, their health scares that they've had.
And sometimes very personal issues people discuss on Facebook.
Extremely personal. And so one individual that I'm friends with on Facebook actually talked about a health situation that she was having. So I reached out to her and asked her if she would submit her story, which she had told a great deal of it on Facebook, but she said no. So it's fascinating to me that there's this reticence. On the one hand, we have this society where we post everything, it seems like, on social media, our minute-by-minute movements. But when you go to ask somebody to tell your story of bad news delivery, there's this reticence to do that. And maybe it's the dialectic, right, between some people are very private, and for them saying, oh, I had to go to the emergency room because I had an accident out in the yard and cut myself, is different than really fully going through and disclosing intimate details of that emergency room visit, let's say.
But you have had a handful of stories here that have been submitted.
Yes.
So give us an example, maybe one or two.
Well, as I said, one...
You can talk about them in a general sense, right? Yes,
the one thing I want to emphasize to people is that I would never betray their identity. But I have had...
The university would drag us over the coals.
They would.
If we did it.
That would be in violation of my IRB protocol. But so one instance was a breast cancer case that was completely unexpected. From the person was in her 50s and found the lump herself and then went through the process of talking about how she initially went to her physicians and then went for second opinion, where they then were able to do biopsies and confirm that it was cancer. So, and in this case, she chose a mastectomy. So that would be like one example. Another person.
Did she talk about how her doctor approached her with the information?
Yes, and not just her physician, but all the care providers in through the treatment process of how supportive they were of her during that process.
So she had more of a exemplary
She did.
relationship here with the medical staff.
She did.
And because they did what? I mean,
Well, because I think they comforted her during the actual procedures.
Yeah.
They were very clear about what her treatment options were. It sounds like from reading the story that they also indicated in no uncertain terms what they were recommending, as opposed to saying, well, you know, sort of the ambivalent, it's up to you kind of thing. But I think her test results must have been convincing enough for them to recommend that she have the mastectomy.
Right.
And she followed that recommendation.
do you have a horror story for us?
I don't yet.
Not yet.
And
Okay.
I mean, I do from past experiences of having worked at a children's hospital in terms of people, but not yet in the study itself.
Right.
And the other thing I'm doing is I'm leaving it open to any diagnosis. Like it doesn't matter. It doesn't have to be a cancer case. I had someone contact me and say, I'd like to tell my child's story. Her child, it was the patient, but she was obviously the decision maker.
Yeah.
And so she asked if she could submit that story. And of course I wrote back and said, yes, we'd welcome any story, even if you weren't the patient, but you witnessed the delivery and the decision making.
What was the situation with the child?
I do not know yet.
Oh,
she hasn't submitted the story yet, but I'm hoping that she will, because I think those are important stories to tell as well.
Yeah, of course, we all have these hearsay stories. But I've heard about, a case in our family. The mom went in, not knowing what her problem was. The doctor diagnosed her, and made another appointment and told her, she had less than a year to live, basically, and walked out of the room. And the dad was having a meal. Ordered a meal in the hospital, and the kids are sitting there with the mom trying to, help her cope with this. And it was, it was just heartbreaking to hear that.
It is.
Partially because, the dad was no more sensitive than the doctor was, actually, from the way the story came out. But I'm assuming that doesn't happen as much as it used to. Because they're talking about this in medical school a little bit more now, aren't they?
Oh yes, they are. But when I was doing my dissertation research back in the day, I read this book by Fred Hafferty called Into the Valley.
Yes.
And he was a sociologist. He talks about how medical students are socialized to dehumanize patients. Because their first major class, right, their first patient is a cadaver.
Right.
And he describes he did this ethnography where he followed a medical school class for a year. And he describes in detail how on the very first day of anatomy lab, the professor comes in and rips back the sheet off the body in the front of the classroom, and then says nothing, turns around and starts writing on the board. And it's like this implicit message that this is not a person.
Wow.
And that's their beginning, that's their introduction to being a doctor.
It seems like obviously there's a bad side to that, right? There's a downside to that, but it seems like they need to, in medical school, they need to somewhat desensitize these medical students, because they need to, act objectively and scientifically often when they're dealing with these cases.
Absolutely.
Yeah. So there's sort of a delicate balance here, then, isn't there? I mean, on the one hand, you've got to distance yourself in order to do your job, but on the other hand, you need to respond to people as human beings, right?
Well, so two comments on that.
Yeah.
One, in the book, Hafferty talks about how with the dissecting of the body, they actually begin with the thoracic cavity, and they didn't used to. But as medicine evolved, they found that was the least human part of the body, the part of the body that would be less associated with it being a human being as
Right.
opposed to the face or your extremities.
Right.
And so they do that.
I'm so glad I didn't go to medical school as I'm listening to this.
Well, I read this book and decided I would never donate my body to medicine.
Yeah.
Organs, yes,
Yeah.
but not the body, right? And so he says, well, they have to do that. You're right, because you can't have them falling apart in the middle of a surgery or while
Right.
they're trying to care
Right.
for you in the
Right.
emergency room. And I found that, many physicians are actually quite sensitive to their overall goals, right, of
Right,
becoming a
right.
doctor because they really want to help people. My second
So
comment.
they're good on both sides of the equation, essentially.
Absolutely, and
Yeah.
I have a great deal of empathy for physicians. This research is not meant to be critical of doctors.
Right.
They have a very difficult job in being able to do this and help
Right.
people understand. But what I would say is that in my own experience of being in the NICU and watching on my very first day in the unit, a neonatologist tell a father that his child was going to die. That was like one of the most picture-perfect examples of how to do that task in a compassionate way.
I can't imagine having to do that. That's so difficult, yeah.
It was horrifying. And the only thing I could say is that that doctor, the only advice I would go back and give that doctor would be, don't do it at the nurse's station, right?
Oh my gosh,
So
yeah.
that was the only thing. But he may have chosen that spot because the father, I think, wanted to still be in eyesight to his
Right.
son's crib.
Right.
And so he, maybe the physician tried to get him to a more private place and
Yeah.
the father wouldn't budge, but I'm not sure. But he did it right in front of my desk. And so I was in earshot of this most horrific news for this person.
Yeah.
And it was incredibly sad, but the neonatologist was comforting, and you could tell that he was emotionally shaken
Yeah.
as well.
So you were working in a neonatal unit
Yes,
while you were going to college.
yes,
And that was your first exposure to a lot of these things.
yes.
Yeah. Can you tell us a little bit more about that? I mean, what's the impact of that on you?
One of the greatest experiences of my life was because I think what it does is it puts in perspective what's really important. When you see, and I feel really honored and privileged to have been part of that team for that 4.5 years that I worked in that unit. They had an over 97% survival rate in the neonatal intensive care unit. And to just see how precious life is and how difficult a job it is to be in healthcare, and just the urgency of it, and especially that particular unit, because many of these parents were not expecting for their child to be born and then to immediately be in an intensive care unit. So there was a lot of emotional work that needed to be done to support the parents and the grandparents of the child as well.
Yeah. There's something called the Spikes model.
Yes.
Can you tell us a little bit about that?
Yeah, so on the back to the care provider side
Yeah.
of the equation, we have Robert Buckman, who is a physician, wrote the book that's used across the country in medical schools to teach physicians how to deliver bad news. And it's this...
Which probably wasn't covered a long time ago, right? I mean, this is a new
like,
step for them.
I'm trying to think of the
At least
publication
in my lifetime,
date.
it's probably a new step. Yeah.
80s, 90s maybe was the publication date of the Spikes model, but it's still widely taught. And a lot of great information in there about some of the things we just talked about.
Yeah.
Making sure that the setting is private, making sure that the receivers of the bad news are sort of mentally prepared, entering into what steps could be taken in the future, what social support they have. So overall, a really decent, approach to doing this. The one criticism that health communication scholars have come up with, in contrast to Buckman's model, is that he treats the situation very one-sided. In fact, I remember reading in his book that he used the metaphor of comparing a patient to like a barge that needed to be moved.
That's an unfortunate reference, yeah.
Yes. And so it sort of took the humanity out, what seemed to be a very humanistic approach. Then I thought, wow, okay, if this is the way he views the patient as not, and
Of course, he's starting from scratch if he's one of the first authors on this, so yeah.
right, and so then there have been other health communication scholars and medical practitioners who've come along that wrote a book on patient-centered medicine. So taking this very patient-centered approach where you enter into the interaction with the goal of completing your task,
Right.
but at the same time not trampling on the patient's goals in the interaction as well, right?
Yeah.
And so we have a pivotal book called Patient-Centered Medicine. Then more recent, some health communication scholars came out with something called the comfort model, which addressed Buckman's weakness, which was it took into account the dynamic interplay of interactions, and that the patient is going to bring with them their own set of expectations and their changing dynamics on the ground in the interaction itself.
And this, for you, this gets very close, of course, to your area of expertise, which is interpersonal communication, right?
Correct.
So it brings it, sort of moving it away from a speech act kind of approach to a more of an interpersonal.
Right, and so when I first started studying health communications, one of the studies that I read that really got me excited about looking at how does communication impact health outcomes was a study done by, I think it was Greenfield and Ware. I'm missing a third author, I'm sure. But it was a study which they looked at how communication impacts actual well-being in a hospital. So they did an experiment where they took patients and they divided them into two groups. So they had the control group and they had the experimental group. In the experimental group, what they did was they went and visited each patient, the anesthesiologist did, and gave them a rundown of what was going to happen in their surgery. These were all patients having the same surgery. What to expect, what kind of a pain they might experience afterwards, what they would do for them if they had pain, right? And then with the control group, they just approached the pre-surgery consultation the way they normally would. They didn't do this sort
I
of...
hope this wasn't some life-threatening surgery.
No, I don't think it. I think it was a routine surgery.
Okay, all right.
So what they found was that the experimental group, who got the little extra TLC of communication, right? They went home quicker.
Yeah,
they were discharged quicker. They used fewer narcotics post-surgery as well. And I was like, this is incredible, right? You have an actual link between, in an experimental study, between communication and physical and emotional well-being. And so I thought, this is what I want to study. This is where I became so passionate about it, which led to my first thesis study, which was on the effects of talk and touch on the recovery of premature newborns, which is what I studied, you know, using the same.
So we just have a minute left, but give us a piece on that.
Okay, so very quickly, this study was done in the 90s. A lot's been done since then. But I will tell you that, and it wasn't experimental, it was correlational. But I also found that the babies who were touched for longer periods of time, not number of touches, but length of time, went home sooner as well.
Interesting, yeah. So the same result, essentially.
Essentially.
You know, one of the first things that I ran across along these lines was Kubler-Ross's death and dying.
The stages, yes.
Stages. Did that sort of initiate some of this discussion historically? I'm just curious if that played a role in this.
Oh, I would think it would have to, because that was such a pivotal model in the study of grief and death and dying and how care providers counsel patients and families.
Because I would think there's some parallels between finding out that you maybe have a life-threatening illness and finding out about a death, right?
Right, because the stages correspond to that, whether there's a death, right? Denial and anger and bargaining and you know, depression. And so you finally get to acceptance.
Yeah, that's interesting. You know, one of the things also I wanted to ask about is one of the strategies I understand is dosing. In other words, you give the patient the bad news a little bit at a time, basically. It seems to me, I mean, I get that, it makes sense, but it seems to me there's also a bit of an ethical issue there? I mean, doesn't the doctor have a responsibility to give someone the full information? How do you feel about that?
Right. So you go back to the Hippocratic Oath. To their
Yeah.
first oath is to do no harm.
Yeah.
So really pivotal researcher in the field of bad news delivery is a guy by the name of Doug Maynard. And he wrote an article where he talks about forecasting, he calls it. So like hinting at the news. Sometimes that works and sometimes it doesn't work. So that might be equivalent to what the dosing of the information.
Yeah, that's sort of a gray area here, isn't it?
Right.
Are there a lot of areas like that, or most of the time is this, is this something that doctors can learn and practice?
Well, it's something they
with a
can
little effort?
learn, but what I tried to advocate in my own publications is that while the scripts are great, like the Buckman's Spikes model, it's not the be-all, end-all. Sometimes you got to let go of the script, right? And then the last thing I would say on this is to quote Bernard Lown, who wrote a book called The Lost Art of Healing, and he said, "Words are like a two-edged sword. They can maim as well as heal."
Oh, very good. That's all the time we have for our program. Thank you to Dr. Gillotti for joining me today on the Roundtable Perspective. I'm Tom Roach. See you next time.